All right, everybody, welcome to the Ultrasound Lecture Series this week. Thank you for joining us. We are getting close to the end of this semester, I guess, as it were. The weather's warming up, and we're kind of getting to the end of the academic year. But we still have some great topics today and in the future weeks. So today we're going to just do a little dive back to some cardiac cases. I figure let's do some cases. Let's talk a little bit about how we think through ultrasound, different ways to apply bedside ultrasound when it comes to cardiac cases. And hopefully that gets not just in the meat and potatoes of how do you do the scan and what windows do you need, but really how do you think about that scan? Like when you're doing the study and you're getting their pictures and we're evaluating the clinical scenario at hand, what steps do we need to go through in our thought process to get from the patient's presentation to a coherent differential diagnosis and start weeding through that with our ultrasound. So without further delay, we're going to dive right into that, and let's go into talking about some bedside cases, or cases in bedside cardiac ultrasound. So this is a presentation I put together a couple of years ago with some cases that we've seen here. I think for the purposes of confidentiality, I just want to make a little bit of a disclosure at the front end. A lot of the demographic details have been changed, modified, manipulated, adjusted, really so as to preserve the privacy of the patients that were being scanned. None of the changes are really in any way, shape, or form affecting the ultimate anatomy, physiology, pathology, things that we need to think through on our ultrasound. But really, for the sake of patients' privacy, we've adjusted some of those demographics so that they're a little bit more obscured. And so, with that being said, we'll move forward. So, with all presentations, that involve CME, for the people who are watching this live, there are no disclosures to make here. And our objectives today is basically to review some cases in bedside cardiac ultrasound and discuss cardiac pathologies relevant to emergency medicine and critical care. And that's really who joins a lot of these conversations and talks, so that's kind of who we're going to gear this to today. So this article is probably one of the best articles that I've read about how to do bedside cardiac ultrasound in the emergency department or the critical care environment. And if you haven't read it, I highly recommend that you go pull it and read through it. So it was published in Academic Emergency Medicine a few years ago by the folks out of Yale, and they really did a great job of summarizing the basic cardiac ultrasound and what are some things that you want to look for, right? And really dividing that into 5 distinct categories where we can go to the bedside and we can put our probe down. We can get some pretty decent yes, no with a little bit of graded answers in there, right? And if you remember way back from Sid's lecture, at the beginning of the academic year about his pathway to critical care echo and shock, he really covers in his own organizational pattern how to do these 5 things. And so this is a really helpful, really illustrative article that I highly recommend you pull. But really it breaks cardiac ultrasound down into 5 distinct things that we're looking for, right? And it's going to be the presence or absence of a pericardial effusion, right? What is the rough ejection fraction? And when I think about this, when I do this, and even when I teach this, I really like breaking this down into, is it hyperdynamic, is it normal or hypodynamic, or depressed? And then we can kind of further subdivide that there, and we'll get into that. The equality, we're talking here about the chamber size equality, so left ventricle versus right ventricle. Are they the appropriate sizes? Then we're looking at the exit, so the aortic outflow tract. Is there any abnormalities there? And the entrance, right, the IVC, or basically preloading conditions. And so they came out with this chart inside this article, and it was really, really helpful, saying, okay, do you have an effusion? And then if you do, how are we going to grade it? Small, moderate, or large? So 1 to 2, or greater than 2 centimeters is kind of the criteria that they're using for small, moderate, or large. And then is there any evidence of tamponade physiology, right? The second thing, ejection fraction, they're talking about hyperdynamic, so greater than 65% ejection fraction, normal at 50 to 65%, or depressed. And when I talk about this, I subdivided this into kind of like what they do, severely depressed or moderately depressed. There's some gradation in there. We can kind of use some overlapping terminology, but really that's kind of the subcategories of depressed. And then obviously, is there no cardiac activity? And we can use a couple different metrics for evaluating that. So the global gestalt, we can use that. We can use the E-point septal separation. We could talk about fractional shortening and various other different metrics. And we've talked about these a little bit on this forum in the past. And then the third one is equality, right? We talked about that. with the right side versus the left side. And really looking at that ratio, is the RV smaller than the right side? The normal parameters are 0.6 to 1 ratio RV to LV. And so if you get greater than 1 to 1 on the RV side, then we're thinking about some signs of right heart strain and everything that brings in, into the differential. And then for the exit, we're looking at that aortic root. Namely, that aortic root should be less than 4 centimeters in diameter. And if you're greater than that, then that increases your risk of having some dissection physiology or aortic aneurysmal physiology going on. And finally, the entrance, looking at that IVC. And I know this is highly controversial, but still it's a helpful data point. Looking, is that thing flat? Is it kind of normal size and phasicity? Or is it full and plethoric and not really moving with respirations? And you can do the caval index and calculate that, but it really gives you an idea of your preloading conditions. Maybe not your volume status conditions, but at least your preloading conditions to see, do you have a high, normal, or low CVP state. And so those are kind of the 5 E's, the summary of the article. And the article itself goes through a lot of detail about how you get to there and how you calculate that, how you analyze that. But with that background in place and that framework, let's actually dive into some cases and talk about how we can use this framework at the bedside to really come up with some clinical scenario or clinical answers here. So the first case that we're going to discuss today is a 60-year-old male presents to the emergency department with respiratory failure and low saturation. So they come in, they're hypoxic, and they're not breathing all that well. Their vital signs are super hypertensive, so 215 over 157, heart rate's 141, so very hyperadrenergic. They have a respiratory rate of 30 and SATs are 91%, and that's the best we can get on CPAP. That's the best we can get on CPAP, and we just have to turn the oxygen all the way up, and we're just really not getting anything better, right? So that's the clinical scenario. I think we've all seen this one. We've all had patients roll into our departments that look like this. And when we get in there, and get the first assessment of the patient, we can start with the ultrasound and get something that looks like this, right? And I forgot to loop that, so I'm going to back it up. And we'll go like that. So what do we see, right? We see basically a lot of B-lines here obscuring the heart. And when we look at the heart, we can see that its squeeze is really not all that great. But if we work down our 5 E's, right? The effusion, the ejection, we don't really have an equality side. We don't really see the entrance or the entrance very well, maybe a little bit of the exit. We can see that there's no effusion, right? We have a depressed ejection fraction, and that aortic root, really not the best window to assess. Well, it is a good window, peristernal long, but we really don't have the clearest view, but it doesn't seem to be grossly abnormal, right? And so we go into the next one. Here's our next view. We see on our pleural exam just a ton of B-lines sliding back and forth on this patient in the anterior and the apical lung fields, right? So moving forward to the next window here, we have this one actually loops or peristernal long. Again, we can see that we have no effusion. So there's a peristernal long. You can see the descending thoracic aorta there, and there's no effusion between the heart and the descending thoracic aorta. You can see a reduced ejection fraction as part of this assessment. And then we go to the chest x-ray. We get a patient that has a chest x-ray that looks a lot like this, right? And so we see, it's obviously rotated and tilted, but a lot of pulmonary edema in this patient. And so this one's a pretty easy one. I think we all had the answer really at the starting slide, but this is a patient who basically has flash pulmonary edema. And so as we work through the case, we can see in the right clinical scenario, we have someone who's got no effusion, right? It's easy. We have a reduced ejection fraction, and we have lots of pulmonary edema. So this is basically the picture of, an LV failure causing that hyperadrenergic drive to get you the flash pulmonary edema. So the take-home case or message on this one is basically looking at how to assess LV function, right? And so here's going back, looking at the apical forechamber, and we can see basically a reduced squeeze. And this one, by Gestalt methods, you can just tell that there's not a lot of thickening, not a lot of excursion of those ventricular walls into the center of the chamber, and so the function is reduced on this patient. Compare that to this one that has a little bit more of a normal squeeze. It has a very different profile, very different picture. And this one, it tends to be a little bit more hyperdynamic. So we see a near complete obliteration of the LV chamber, right? You have those kissing ventricles as the ventricular walls touch one another, suggesting that this patient has a large proportion of the blood that it's in his chamber being ejected out of the heart. So let's talk a little bit about EPSS for a minute, because all that's well and good. I mean, we put that probe down, and we can see between those three different scenarios that there is some obvious differences, right? You can look at one and say, this looks reduced. You can look at the third one and say, yeah, this looks hyperdynamic. But it definitely requires a lot of, seeing a lot of other scans and seeing a lot of other images to kind of have that mental library, as it were, of normals so that you can detect the abnormal. And with a little bit of practice, it's certainly doable, right? You can certainly be reasonable in your assessment on a gestalt, but it's certainly helpful to have some tools from time to time to add to our gestalt so that we can really check our work and clarify that this is, in fact, a reduced ejection fraction. So I like to use the EPSS as a way of checking that, because it's not too terribly difficult, and it gives you some numbers that you can rely on. So in general, the EPSS is basically the endpoint septal separation, and what we're doing is we're measuring the distance between the mitral valve leaflet tip in the peristernal long axis window, measuring the distance from that leaflet tip to the septum when the mitral valve is completely open, right? When the EPSS measurement, right, when that measurement is less than 7 millimeters, it correlates with a normal ejection fraction, and anything above 7 millimeters correlates with a depressed ejection fraction. And to be perfectly honest, there is a formula you can plug the number into and get a reasonably accurate calculation of the ejection fraction, but that formula is just something I can't easily remember, and I don't know if it's really important to remember because we can Google it whenever we want. But it definitely gives us a way of quantifying that ejection fraction. So here's an example. So we have their peristernal long axis window, right? And you can see in the middle of the M mode is a black stripe, right? And this reflects the chamber, the LV chamber, and that line that's at the bottom edge of the black stripe, the line that has the excursion from the baseline, has those little peaks throughout the chamber. That's the anterior leaflet of the mitral valve, right? And we're looking at how close do those little peaks get to the top line, the top border of that black line on the MO tracing. And so maybe we'll put some calipers, make it a little bit more obvious here what we're looking at. But the first hump is basically the passive filling of the LV. So the mitral valve opens up with passive filling and diastole. And as the filling slows down, that mitral valve leaflet tends to close back down. And then the second hump is that atrial kick. So when the atrium fires and contracts, then we get a little extra blood flow into the left ventricular cavity from the left atrium, and that's the second hump. And so we want to measure the first one, the tallest one, and that is really going to be the distance from the left the mitral valve leaflet tip to that septum. And if that's greater than 7 millimeters, which in this case is 3.5 centimeters, so we're talking about 35 millimeters, that suggests a very, very low ejection fraction in this particular patient, right, or in this particular image. So there's a few pitfalls that we have to keep in mind. Not everything is perfect, and while this is a great test, there's a few things we need to do to make sure we're doing it accurately. And the first one is just positioning it properly. As you can imagine, you can position the septum in less of a horizontal orientation and more of an oblique orientation, and that will dramatically increase the measured distance on M mode between the leaflet tip and the septum, right? So you really want to make sure that you have the septum of the LV, right? The LV, or the cardiac septum, is horizontal as you can get in your peristernal long axis window, so as to optimize and minimize that distance between the leaflet tip and the septum when it fully opens on your M mode tracing, right? Because you can't adjust for the angle of the M mode other than kind of put where your M mode cursor is, and so that's going to certainly artificially increase your distance, which will artificially decrease your measured ejection fraction. Secondly, if you have a stenotic mitral valve, right, your valve is not going to open very well. Your leaflets are not going to move very well, and that certainly will also artificially increase the measured distance and artificially decrease the measured ejection fraction, when in point of fact the ejection fraction may be normal, but just because it's stenotic, it's not really going to reflect that in your measurement. So a couple things just to remember: it's a good technique, right, but it requires just some careful measurement and reminders of the pitfalls. So case number 2 is going to be a 52-year-old female who presents to the emergency department with cardiac arrest, or at least they had cardiac arrest, and the EMS did a great job, and they were able to achieve ROSC prior to arrival. And they dropped the patient off and said, hey, they're just sitting around, right? They keeled over, We worked them a little bit and they got ROSC, and here we go, right? So in the post-resuscitative care, we do an ultrasound and take a look, and we find this. And so here we can kind of run through our 5 E's. So from an effusion standpoint, do we see an effusion? Well, there's a little bit of a hypoechoic or anechoic area in the anterior portion of the heart, maybe a little bit around the apex, but certainly not a ton at the posterior aspect. And the way to measure an effusion is it present in complete diastole, right? When the heart is as full as it gets, is that thing still there? And in diastole, I don't really see a ton. And so there may be some trace pericardial fluid, but I'm certainly not going to call a significant or concerning effusion in this patient, right? So the next one is going to be ejection fraction, right? Do we have a normal, a depressed, or a hyperdynamic ejection fraction? I think it's pretty safe to say that this isn't hyperdynamic, and it really doesn't fit the category of severely or even moderately depressed. So I'm going to say this is a relatively normal ejection fraction. There's going to be some error bars around that that we can, account for, but certainly it's not going to be this hugely depressed ejection fraction. So it brings us to our next one, equality. Is there left-right equality? And this is probably not the most ideal window because we're certainly rotated and foreshortened on the LV and exaggerating the RV in this particular window. So I'm going to say we're going to have to punt to a different window to get that assessment as we think through the patient. And then entrance and exit are really not identified well on this image. So what we're left with is basically a decently normal ejection fraction, maybe some trace pericardial fluid, but we're not having any smoking or finding any smoking guns yet. So let's switch to another window, right? Here's the parasternal long axis window. We'll make this active. And so we're going to just confirm those again. So no significant effusion. Let's back that up. The ejection fraction looks a little bit more depressed here. We do have an area, back up. We do have an area where we can measure the distance from the mitral valve leaflet tip to the septum, so we can kind of confirm whether or not our initial gestalt was right or wrong. Based on what I'm seeing, I'm going to just give them a little bit of a ding and say it's probably a little bit reduced, maybe not severely reduced, but we're going to say at least moderately reduced ejection fraction. And as we move on to the apical 4, it's certainly going to be a little bit tilted off to the side, so not a perfect apical 4. But there's one structure in here that really just jumps out and stands out, right? And so we see that just a little bit to the right. So the very, very middle chamber that we're seeing in this image is the left atrium, right? We have the left ventricle toward, above that. But the chamber to the right doesn't make any sense because it's not correlated with the ventricle. So it doesn't seem to be the atria. And in fact, if you look to the left of that center chamber, that is the right atrium. So we have this extra thing that's just off to the side of the left atrium, right? And so we think back on anatomy, the thing that should be there is the descending thoracic aorta, right? So this is a very, very large descending thoracic aorta. And even though I don't have calipers on this right now, you can definitely see that it approximates the size of the left atrium, which is certainly not a small chamber by a stretch of the imagination. And so this thing is definitely greater than that 4 centimeters in diameter that we would be expecting, in at least the aortic root, although at this point it probably should be a lot smaller than 4 centimeters. So we move on to that. We saw that. We're like, this is kind of interesting. Let's interrogate that a little bit further because we have a patient who arrested and got ROSC, and now we have a large dilated descending thoracic aorta. So is it aneurysmal? Is there a dissection? So we went into long axis, and we scanned basically, here's the long axis, looking to see if we could find a dissection flap, right? And if you look off to the right-hand side in the long axis of the aorta here is a small little echogenic line inside that aorta, and that caught our attention, right? From this window, I can't say for sure that is or is not a dissection flap, but it certainly alarmed us, right? There's certainly, you can have some artifact that can cause things that are similar to this, but it certainly got us concerned that there could be a dissection in this patient, right? And actually, as you look here, there's a little bit more obvious pericardial effusion in this patient, though certainly not large and not likely the cause of the patient's sudden imminent demise, right? As we're scanning a little bit further down into the belly, trying to follow the aorta, trying to see if we can find any signs of dissection that would suggest, this diagnosis sonographically. And again, we get this either artifact versus dissection flap as we scan through. So nothing that's definitive, but certainly concerning. So the patient eventually went off to get a CT aorta to identify and see if they had a dissection. And lo and behold, we were right. So this patient had a large type A and type B dissection. So from aortic root all the way down to the iliac vessels, there's a large dissection. So the answer for this case is aortic dissection, right? And I thought it was an interesting case, brings up some interesting topics. So things that you need to think about, or this is one of the things that you need to think about when you have dilation of the aorta or the aortic root, right? So we talked about the exit, the measurement being of the left ventricular outflow tract measurement being 4 centimeters or less. When it's greater than 4 centimeters and definitely greater than 5, you certainly have to have this high on your differential, especially if it fits the clinical scenario. In this case, the patient had cardiac arrest, and so aortic dissection is certainly an extraordinarily reasonable differential. What it generally tends to be is a linear, excuse the fact that I misspelled it there, but a linear mobile echogenic structure inside the lumen of the aorta, right? And if you put color Doppler on it, what you might know is a differential in the color Doppler flow patterns between the true and the false lumen. It's hard to tell which one's which, but you should see different velocities in the true and the false lumen. And there's a couple different ways that you can look at this. So in this situation, we had we found it just doing the apical 4 and saw a very, very large aorta just off to the side. And so you can look at that. You can turn on long axis there. The other way you can look at the aorta is look at the suprasternal notch view, kind of getting that candy cane appearance, looking at the aortic root. So here we can see kind of that arc from in the near field kind of heading into the far field. So that's the aortic root. And then emanating from that will be the cranial vessels, heading up towards the top of the ultrasound image of the pie. And we don't really see any obvious dissections in this view, but you can throw some color on it, and you get that differential in color flow that you can see in that descending thoracic aorta right there. That would suggest the possibility of an aortic dissection. Now, is this going to be the sine qua non, only test you'll need? Probably not, but it certainly can get you headed down that road, right? Getting you thinking about the differential of aortic dissection, and you can follow that up with further imaging, whether it be CTA, or other forms of imaging as appropriate to make that diagnosis, right? And so here's another example of that suprasternal notch root or look, where you can see basically the candy cane, the arch, the proximal portion of the arch will be to the left side of the screen. The distal part of the arch will be to the right side of the screen. You can see the carotid vasculature as it's branching off on the top part of that root, right? So complications of aortic dissection, we all know these, right? Aortic regurgitation. You can have vascular occlusion, or you can have rupture of various things, right? Pericardial rupture, pleural rupture, mediastinal rupture. And so it's unclear what caused this patient's demise. My suspicion is it's probably some form of vascular occlusion. They had a coronary occluded by the dissection flap. They became ischemic and coded because there certainly wasn't a large amount of pericardial effusion causing tamponade physiology. It just didn't fit that bill. So I suspect there's probably some vascular occlusion in the context of a coronary occlusion. So we'll never know, but that's what happened with that patient. So our next case is a patient who was stabbed in the chest, right? And for context, this patient was stabbed in the cardiac box. And what I define the cardiac box is basically nipple to nipple, clavicle to probably the subxiphoid area. So if you're stabbed anywhere in there, you really have to be concerned about the heart, right? And in fact, if you have penetrating trauma that not only just is in the box, but traverses through the box, right? Something that maybe you got a gunshot wound to the lateral side of your chest and it came out the other lateral side of the chest, that has the chance or definitely traveled through the cardiac box. And so you really need to be concerned about injury to the cardiac structures, and not just the lung structures, but injury to the cardiac structures. So that's definitely going to be, an immediate concern based on the stem of this patient's presentation, right? So the patient was stabbed to the chest, right, just left of the sternum, in that precordial area. So that's highly concerning, right? Their heart rate is 110/80. Their blood pressure is 110/80. Their heart rate is 85. Respiratories are 18, satting 98%. So this is good, right? They seem to have relatively even and unlabored breathing. Seem to have a decently good sat. Doesn't rule out a pneumo, right? But it certainly is reassuring as we go into this patient that we need to probably focus more on the heart than the lungs, but certainly both are of concern. And so as we go in, we'll look at the lungs, right? So here's the left side, right? And we put an M-mode caliper between the rib spaces and look at the pleural line. We can see that sandy beach. It's a little dark, right? But you can see that there's a definite striation in the near field and definite granulation in the far field, suggesting that sandy beach or the normal lung sliding, right? And so when you think about this, right, when you look at it at one rib space, that really only rules out pneumothorax in one rib space. But I suspect if they were stabbed in the chest on the left side and they had a pneumothorax, it's probably going to be pretty decently sized, and I probably should see it in more than one rib space, right? And certainly if you have a tension pneumo, right, I should see it in multiple rib spaces along the anterior fields. So while this image alone doesn't rule out a small, tiny pneumothorax, I think that it's probably helpful in lowering the differential diagnosis for a tension pneumothorax, right? If you have a tension pneumo, I suspect we'd see signs of pneumo no matter where you put your probe. Again, not 100%, but it's kind of it's just kind of a general gestalt type thing. Right, so certainly you can slide up and down and look at the entire anterior lung fields in a supine patient, definitely rule out the pneumothorax. But we don't see anything obvious. So in this situation, time is of the essence. You have a lot of other things to look at. I'm going to go look at other things, and I can come back if I need to circle back here. Right. So we'll look at the right side. Again, we see the rib and pleural line on the right-hand side of this image, and the M-mode caliper showing us the tracing on the left, and we see that striation in the anterior fields, right? You can see that granulation in the deep fields, suggesting that there is normal lung sliding at this rib space. So from a large size pneumo tension physiology, not likely, right? At least on the left and the right. I think I can keep looking and seeing what's going on with this patient. And again, I can circle back either with my ultrasound or other forms of imaging to rule out a small pneumothorax, as we get further into this patient's care, right? So let's look at the heart, right? So here we go. So the first thing that hits us, we have a subcostal window of this patient's heart, and you see we'll go down our E's, right? Is there effusion? Yeah. We didn't have to get very far, right? We have a definite pericardial effusion. So a patient who's stabbed, right, to the precordial box and has a new pericardial effusion or just a pericardial effusion in general, we have to presume that this thing is new, right? We have to assume that this is related to their acute trauma and move from there. And so I think we're going to go on. We're going to see more pictures with the patient, but I think we're also done, right? We know that they have an injury, a likely injury to the heart, and they need to go to the OR and get that injury explored and get it repaired because what looks like they're bleeding into the pericardial sac, right? But the story obviously isn't done there, and we're going to keep moving on here. So we have this image, right? We're going to move to the next image. So there's a little bit of time delay, just with some some logistics of getting the proper people in the room to evaluate this patient. But we basically were able to watch over the course of a few minutes and see what happens as that effusion collects a little bit further. And what we see here is that effusion's a little bit larger, but we see a little bit more compromise of that RV chamber in diastole, right? You can see that undulation of the RV free wall, suggesting that this patient is not just in the early stages, but kind of heading down the road of pericardial tamponade, right? So this patient definitely needs to go to the OR rather rapidly to get this assessed and get this repaired. So this patient has pericardial tamponade, right? So let's talk a little bit about the physiology of tamponade. And I think this graph is really helpful as we think about tamponade. So on the top, you have your cardiac output and your mean arterial pressure, right? So the two aren't completely synonymous with one another, but they tend to correlate, right? So, and in this graph, you can see your cardiac output, your mean arterial pressure there. So kind of the effects of what the heart can do, right? And in the bottom, we see our loading conditions, right? So we have our right atrial pressure in the yellow line, right? And we have our pericardial pressure in the red line, right? And so as long as our right atrial pressure exceeds our pericardial pressure, we're going to fill our heart, right? We're just going to have that passive gradient that allows blood to fill into the heart. But as soon as our pericardial pressure exceeds our right atrial pressure, now all of a sudden we have a force to work against, right? We have something fighting that blood that's trying to fill the heart. And we're going to start seeing decrease in the heart's ability to fill. And downstream effects of the heart's ability to then squeeze that blood out of the heart. And so what we're going to have is compromise in our mean arterial pressure, and we'll have compromise in our cardiac output. And this is really what tamponade physiology is. It's an inability of the heart to fill due to the volume of fluid, not just the volume of fluid, but the pressure that volume of fluid exerts on the right side of the heart, the right atrial pressure and the right ventricular pressure, those filling pressures, and preventing that right side to fill. And when the right side doesn't fill, then it can't send that blood through the lungs to the left side, and the left side can't pump it systemically to supply the rest of the body, right? So that's pericardial tamponade in a nutshell. And so what we're going to see is various different sonographic effects of this phenomena that happens, right? And so the first one, the most obvious one, is we're going to see a large and plethoric IVC. And this makes sense, right? If we can't fill the heart, we have increased resistance to filling that heart, that blood is going to back up into the next proximal thing. That's the IVC, right? It's the capacitance chamber, essentially, of the vascular system. So when you store blood, it's stored in the venous side, right? And if you can't get blood to the heart, it's going to back up and it's going to distend the venous side, right? That IVC. And so that IVC will be plethoric. And I think it's safe to say that if the IVC is flat and collapsible, it's not storing the blood, it's not distending it. And so tamponade's less likely your issue. But when you do see tamponade, right, you're going to start seeing this plethora of the IVC, right? The next thing that we're going to notice is collapse of the next lowest chamber pressure wall, right? And if you think about it, the lowest pressure chamber in the heart is the right atrium. Right? The pressure in the right atrium is somewhere between 0 to 5 millimeters of mercury, depending on where you are in the cardiac cycle. And so as you have fluid or blood around the heart that's exerting a pressure on the right atrium, it's going to prevent that filling until the pressure in the pericardial sac is exceeded by the pressure inside of the fluid exerting pressure inside that right atrium. And so the lowest pressure state of the right atrium is while the ventricle is in systole, right? Because the atria has already done its job, it's squeezed during ventricular diastole. The ventricle enters systole, it closes that tricuspid valve, and as the ventricle is squeezing blood out, right, out the pulmonary artery and into the lungs, the atria is going to relax and start filling, getting ready for the next cycle, right? And so that beginning of relaxation is the lowest pressure time in the cardiac cycle for that right atrium, And so what we're going to see is that pericardial fluid is going to exert pressure in that portion of the cardiac cycle, not allowing it to fill. And so you'll have that collapse of the RA free wall that we see here in this image. And in fact, if that RA free wall is collapsed for greater than 1/3 of the cardiac cycle, right, the whole cycle, it's actually highly sensitive for tamponade, right? Now, I don't really measure all the time the duration of time that thing is indented into the right atrium. But if you save a clip and slow it down and say, hey, there's a large part of this cardiac cycle where this thing's indented in and not allowed to fill completely because of the pericardial fluid, then you really have to be concerned about pericardial tamponade, right? So that's right atrial systolic collapse. The next one is right ventricular systolic collapse. And the same phenomenon, you just go downstream one step. And in this case, it collapses in ventricular diastole, right? It's the lowest pressure time of the ventricle, right? And so the ventricle generally sustains a pressure of about 10 to 25 millimeters of mercury. And so when you have this thing relaxing after it's squeezed, right, after it's ejected its fluid, it's going to have that indentation of the RV free wall that we see on the top of the screen here as it goes through its cardiac cycle. Right, and so that's another finding that's suggestive of pericardial tamponade in this scenario when you have an effusion, right? And so, putting these things all together, this kind of gives us the picture that this patient has hemodynamic collapse from pericardial tamponade. And so, what this patient needs, since this is a traumatic tamponade, they need to go to the OR, right? They need to go get this pericardial space opened, that tamponade relieved, so they can fill, and then they need to find out what that source of injury is. And one just quick pointer here for when you're at the bedside, if you're starting to lose your pressures, right, probably the best thing you can do is give a little bit of fluid, right, to get some preload, maybe some pressors, but a little bit of fluid to optimize your preload. But you really need them out of your department into the OR to get it fixed. The worst thing you can do is you can intubate the patient, right? This needs to be done as late as possible as close to as possible is when you get this patient in the OR. And it usually needs to be done by the anesthesiologist. And the reason for that is when you convert the thoracic space from a negative pressure to a positive pressure, you increase the amount of pressure that the pericardial sac exerts on the right atrium and the right ventricle, and you precipitously decrease the RA and RV filling. Right, so you need to be really careful when you have these patients to not intubate them too early, because that may cause their condition to get worse. And you try to avoid that at all costs until you can get them up to the OR. So the next case is my oxygen blew up. Right, so this is unfortunately not an uncommon scenario, but you have a COPD patient who is COPD because they smoke, right? And they need oxygen because they have COPD, but they haven't kicked their smoking habit. And so they're sitting on their couch or wherever they are. They have their nasal cannula on, running their oxygen. They put a cigarette in their mouth and they light up and poof, the whole thing goes up. And they come in looking like they're in the movies with their hair slicked back and kind of soot all over their face, saying my oxygen blew up, right? So that's what happened for this patient, right? So we have a 72-year-old female who is smoking with oxygen, and that oxygen flashed and exploded in her face, and now she's coming in saying, I'm feeling short of breath. But I've been feeling short of breath for the last week. In fact, I can't even lay flat anymore. And when you look at the monitor, her SATs are about 85%. So you're left with this conundrum. What's causing this issue, right? Why is the patient dyspneic and hypoxic, right? And so the first and most obvious thing that you want to think about is, or at least people think about is, well, they just had an explosion in their face. There must be some thermal injury. And while that's, I suppose, possible, in the context of a flash fire from oxygen, lighting up oxygen in their face, most of that fire happens just right in front of them, and they generally don't inhale superheated gases and cause lung injury. In fact, as I talked to some of our burn surgeons, in order to get lung injury from superheated gases, you really need to be inside a burning room, right, where you have the superheated gases to breathe. By the time you breathe this oxygen that blew up in my face, you may notice some injury to like the front, of your nose, the front of your mouth, but really not much deeper than that, generally speaking, right? So probably not causing, the proximate cause of this dyspnea and hypoxia is probably not their explosion, right? In fact, the 1 week's history of dyspnea and the progressive orthopnea really speaks to the fact that there's probably something else going on, right? And so here's the patient's x-ray, right? You get the obligatory x-ray, and the radiology read is they have some opacities in the bases. It could be a number of things. It could be atelectasis, could be effusion, could be infection. You guys figure it out, right? We're just telling you that it's there. You guys, your job as clinicians to figure out what's going on. So that's decently helpful, but pretty unhelpful, when there's a large differential to continue to weed through. So throw in some ultrasound, see what we can find, right? So here's the patient's parasternal long axis window. And so as we look at this, we can run down our E's. So is there an effusion, yes or no? No, I don't see one, right? What's their ejection fraction look like? Honestly, it looks half decent, right? You can see that anterior leaflet of the mitral valve opening and almost touching that septum, right? You can see that the ventricle squeezes pretty well. So I'm going to say it's a pretty normal ejection fraction, right? Really not a great window to measure equality. Your exit, the aortic root, looks to be appropriately sized. We don't have calipers on here, but you measure it's going to be less than 4, and we don't really have a good view of the entrance in this patient, right? So not a lot to go on here that's going to help narrow this differential. So let's go to our next window, right? And here we have our EPSS, and that really corresponds and correlates with what we just saw, right? You have that anterior leaflet of mitral valve that's approaching and touching the septum, and it really kind of says, yeah, the ejection fraction is pretty normal in this patient, right? So if we go to the parasternal short, right, we're going to look for basically roundness of the ventricle, see if there's any flattening. And I don't really see any flattening of that RV, or the septal wall into the RV, right? Maybe a touch, but it could just be just the angle that we have, right? The RV looks a little bit big. And if we go to the apical forechamber, we can see our our left ventricle and our right ventricle. And what we notice here is we've gone down the first two E's, the effusion, the ejection fraction. This one's a good one for equality. And what we're seeing in this window is that the RV seems to be a little bit bigger than it ought to be, right? We're going to say that's close to 1-to-1 in terms of RV, LV size, right? And so we're left with someone who's got a larger RV, and a little bit of tricuspid regurg. Not a ton, but certainly a little bit of tricuspid regurg as we scan through this patient. Looking at the RV function, right, we can put the MO caliper through the lateral annulus of the tricuspid valve, looking for TAPSE, the tricuspid annular plane systolic excursion. And we measure that, and we're looking at about 22 millimeters or 2.26 centimeters, suggesting that this is a normal RV function, right? TAPSE is greater than 16 to 18, so it looks pretty normal. If we go over to the pleura, that's kind of where the lungs were a little bit confusing on the x-ray, and we can definitely see a pleural effusion on the right-hand side with collapsed lung behind that. And over on the left-hand side, we see still an effusion, but a little bit less of an effusion, right? And so putting this all together, we basically have a normal ejection fraction. We have a dilated RV, with thickened wall. We didn't really point that out, but the wall looked a little thick. We had some tricuspid regurgin and pleural effusions, right? So the answer to this patient is they had pulmonary hypertension. And there's a lot of other things that we can do to assess, the degree to which they have pulmonary hypertension. And Z has talked about that, this last fall. But all told, this patient has pulmonary hypertension and just the downstream effects of their pulmonary hypertension. And what we take away from this particular image is we had some evidence of right heart strain. We had that enlarged right heart, although the septum wasn't flattened too much. We have thickened wall, and that really brings up a differential diagnosis for us of pulmonary embolism, pulmonary hypertension, COPD, things like that. And so we know this patient's probably got some COPD. It's probably contributing to their pulmonary hypertension. And they're probably just having a decompensation from that perspective, causing their symptoms, right? And the final case that we're going to talk a little bit about is a 15-year-old female who comes into the emergency department in cardiac arrest. Right? So this obviously is a pretty exciting phenomenon because young people generally don't code. And so, obviously everyone's all ramped up to see kind of what's going on. And while in our contemporary age with drug abuse being what it is, that's probably, that's obviously differentials number 1, 2, and 3, but we cannot forget other medical causes of cardiac arrest. And so we have to think through those as the patient comes to our department, right? So they come in, right? And they got ROSC, fortunately. That takes the pressure off. And this is the first image that we see, right? So walking down our 5 E's, so we have effusion, yes or no. Don't really see one. Ejection fraction looks good, right? You have that that distal leaflet tip, the anterior mitral valve leaflet tip. It approaches the septum as it's moving throughout the cardiac cycle. So the ejection fraction looks pretty good. Again, equality is not well viewed on this one. Exit, I don't see a large aortic root, so I'm not thinking like a dissection or something like that. And again, entrance, I can't see well in this one. But there's one major differential in young people who have cardiac arrest that we really need to think about, right? And that is HOCM, right? Hypertrophic obstructive cardiomyopathy. And could they have some obstruction of their LV outflow due to their septum, right? And so the easiest way to measure this is get a clip, right? And then pause that clip right where, I need to go back, right there, right where the aortic valve is open, right? When you have your outflow phase of your cardiac cycle, right? And you want to look and see if that anterior leaflet of the mitral valve is being sucked into that left ventricular outflow tract into the aorta by the Venturi effect as that thing is open, right? In this patient, what we can see is that space is wide open, right? We have the aortic valve is wide open, mitral valve is definitely closed shut, and there's nothing that's obstructing that outflow tract. And so this patient doesn't have that SAM phenomena, the systolic anterior motion phenomena that would be characteristic of hypertrophic obstructive cardiac myopathy. So we can check that one off the differential. So now we need to work ourselves down the differential list again, or a little bit further, right? So let's move on to this one. So you have your EPSS showing definite, excursion of that mitral valve leaflet tip. to the septum, so that ejection fraction is normal. And then we go to our apical 4 chamber, looking at equality, right? So we have our LV on the right and our RV on the left, and that RV is ginormous, right? It's huge. It's definitely greater than 1-to-1 in our ratio of RV to LV. And so I think what this denotes to us is we have someone, a 15-year-old patient who, for all intents and purposes, is normally healthy, right? Has no other pre-existing medical conditions that we're aware of, right? Who has definite acute right heart strain, right? And so this should, in this context, in case of cardiac arrest and ROSC, that should bring up one major thing, and that is pulmonary embolism, right? And we can see in our short axis window, right there, we definitely see a flattening of that septum, which further seals the deal for that RV strain, suggesting that the RV pressures are significantly higher than they should be at this point. So this patient has a pulmonary embolus, right? And when they went to CT scan, that's exactly what was found. So as we think about cardiac arrest, right, we oftentimes talk about those H's and T's, the 5 H's, 5 T's of I guess more than 5, of the things that are reversible in cardiac arrest. And if there's a reversible cause, let's try to reverse it. We've talked about a number of them today that we can identify with ultrasound, and I've highlighted them here with the arrows, with hypovolemia and tamponade or tension physiology, the PE, we've talked about trauma exams in other lectures. And these are different things that we can identify to try to reverse the cause of the patient's cardiac arrest. And this paper came out in Resuscitation in 2016, by Romolo Gaspari and colleagues over at UMass. There's actually a multi-center study looking at what is the likelihood of survival when a patient comes in PE or asystole and has no cardiac activity on their ultrasound, right? And they basically found, I think the key number in this one is 0.6% survival to hospital discharge rate when those conditions are met. And they were looking at other scenarios and what are the rates of hospital discharge in various other scenarios. And this is the largest study, I think, that was done to date in the cardiac arrest world with ultrasound, showing what are the outcomes when we see various different things in our ultrasound. And it really illustrates that ultrasound plays a pivotal role in making that differential and kind of deciding, what are the reversible causes and kind of what is the ultimate outcome of the patient in cardiac arrest. And so just showing a couple examples, here's various patients who come in arrest and, and various different things that we can find on ultrasound. And so in this patient, this is a blunt traumatic arrest with a large pericardial effusion, clotted pericardial effusion, and they're definitely in tamponade, but you can see that they have some cardiac activity remaining, right? So this patient needs to be opened, and that's what happened, right? The clot was evacuated and the patient survived, right? Here's another case, right? So this one, as we look through it, let's get it started here. You can see we're finding the heart. There it is. We have a large pericardial effusion, but no cardiac activity, right? So this is one that basically had tamponade physiology and succumbed to that. That is the ultimate cause of their demise, right? And there's a good article about using the ultrasound to assess for activity and fluid in the setting of trauma to see what the outcomes are, whether it be alive or dead, when you have different scenarios of fluid plus or minus activity, right? The next case we have here, right? Here's a patient who comes in. You see no cardiac activity. So this is if they've got electrical activity, it's PEA. If they don't, it's asystole, right? And so this really fits that scenario of they came in out of hospital cardiac arrest. Initial rhythm was PEA or asystole. They got no cardiac activity. This patient's probably done, right? 0.6% chance of survival to hospital discharge. In this, when you have this scenario, compare that with this patient, right, where you can see there's some quivering of the heart. We'll go back here and show that again. So this patient's got VFib, right? This patient needs to be shocked. That's a totally different scenario than what we just talked about with the PEA. And so this patient needs to be shocked. If you can get it back, then this patient probably needs to go to the lab to look for the lesion, the coronary lesion that caused them to go into a ventricular arrest, right? So hopefully this was a good summary, good review of not only this paper, but showing some examples of how you can apply this paper to the bedside in various different clinical scenarios, looking for those yes-no questions, right? Does the patient have an effusion? And if so, kind of how big is it? Is it causing any hemodynamic effects, right? Secondly, is there any issues with the ejection fraction, right? Is it normal, hyperdynamic, depressed ejection fraction, right? How we can measure that. What's the RV-LV chamber size, right? Are they is the RV bigger than it should be, or is the RV normal sized? What does the aortic root look like? Is it 4 centimeters or less, or is it bigger, right? And what does that mean? And then what does the entrance look like? We didn't really look a lot at IVC, but we looked at it a little bit with that tamponade case. But is it large, right? Does it move with respirations, or does it collapse with respirations, or is it flat, right? If it's flat, we need some preload. If it's large, you have the preload. Now you need to utilize that preload and figure out what else is causing the patient's sudden demise. So with that being said, are there any questions about the material that we presented here, or how you think through this, or things that you guys want to say about this case?